Malposition IOL. Okay. In spite of enough care taken during the IOL insertion, IOL can be found displaced during the follow visits. It's more common with learning phacosurgeons. Malposition of IOLs are not appreciated by patients if the vision is not disturbed. They don't know it unless your next doctor, next door doctor reveals it that the lens is not properly placed. There are reasons. You have a large size eyeball like very high myopic, or you use small IOLs. Intraoperative pupil becoming small and you are in the learning phase, initial phase of your practice. At that time, because you're in a hurry, probably the anesthesia is fading away, then it is possible that your implantation of the IOL is not proper. So these are but the improper placement can be either the one haptic is out of the bag or in the anterior chamber, improper centering, particularly for the multifocal or the EDOF lenses, improper axis alignment, again when the pupil is becoming narrow, or anterior bulging of the lens in the anterior chamber due to the uncleaned visco left behind the IOL, particularly heavy visco. So how to manage it? These patients are unaware about it unless the next doctor, as I told you, it reveals it. Vision is, this is very important, what I've seen in my practice. Vision is not compromised. Explain to the patient before somebody else tells him. Explain, but no active treatment is required. The patient is concerned with the vision. So better explain, be honest. If it is displacement or malposition, a little bit, but the angle kappa is not disturbed, the visual axis is going through, vision is okay. Explain, tell them honestly that it is better. On the contrary, you will win the confidence of the patient. So the counseling is very important. And if you need to do second maneuveration, please do it as early as possible. But again, at that time, you have to take all precautions. See, you see the case report, a very close family friend of ours, the left eye phaco IOL done, Alcon Panoptic story implanted, and post BCVA was 6.9 with minus 1.5 cylinder 140, and near vision was N6. See, I'll show you. You can see here if you can. See, this is the multifocal. I mean the panoptics. But you see, during the implantation, something went wrong, and here is this is the. Anyway, you see the line there. There is a posterior capsule gap. So it was very difficult. Again, you could not dial. So in that case, patient was happy. I explained the patient, we can do it. We can do the LASIK if you want top up. But the patient is happy, no, I don't want to do anything. So it was an explanation from my side that this is a position. So the patient accepted gracefully and okay, fine. So the management, suppose we want to do, we have to go for active management. Then the dialing of IOL, proper dialing of the loop. So because most of the time you need to manage the loop, or dialing of toric IOL in a proper axis. At the most, at times, you need to go for exchange. Now this is what you see here. The lens has been, of course, it is a referred case. I think hardly 10-15 days have passed after phaco, but it is not uneven for phaco. You can see that because I found that there was a little vitreous into the anterior chamber, and it is difficult to dial the lens into the sulcus as it is. So we tried to do that. It was easy, but then additional anterior vitrectomy was necessary. And once it was done, then it was easy. You can see that. See the margin of the posterior capsule. And once it was easy, then we dialed the patient. And now normally what I've seen, the dialing the lens with the anterior chamber maintenance is easy rather than the pars plana infusion. This is how done. Again here you must be slow, careful, and you must take enough time to place the lens properly. There is another case, again a referred case. Uh, there are a lot of capsules, and you can see the tear, and the lens has been displaced, decentered grossly. As it was a rigid lens, it was easy to dial, and we just wanted to make sure that the loops are free and in the sulcus. See, it's not easy. So we did the anterior vitrectomy. You can see the vitreous little bit, visco into the vitreous chamber. And once it was, the AC was clear of the vitreous, then it was easy. To summarize, the cautions during the preoperative, before the surgery is very, very important. And uh, thorough examination is very important, and you must select the IOL properly. Intraoperatively, you must position the IOL in the bag or in the sulcus. And to manage the small pupil, if need be, you have to use either the iris retractor or the capsule care. And the honest counseling and second maneuveration uh, at an early stage is very important. So to take home the message, to avoid such situation, be careful during the surgery, operation. Pupillary management is very important because we have seen that when the people, these residents are learning or in the initial phase of your practice, this can make a problem. And if vision is not disturbed, just watch, don't do anything. Secondary intervention at an early stage is very important. Thank you.